Hey everyone, and welcome to today's Explainer. I am so excited to have you here because today we are jumping right in to demystify a condition that literally affects millions of people, sciatica. We're going to take a really structured look at this, cut through all the complex medical jargon, and turn it into clear, highly actionable insights. By the end of this explainer, you're going to have a total, comprehensive understanding of exactly how this condition works and, more importantly, how it's actually managed.
Okay, let's dive right into this. Here is our roadmap for today. First, we've got 1. The paradigm shift. Then 2. Anatomy and root causes. 3. Symptoms and red flags. 4. Evidence-based treatment. And finally, we'll wrap up with 5. Clinical cases and prognosis.
All right, Section 1, the paradigm shift. A symptom, not a disease. This brings us to our very first major concept today. And honestly, it requires a total shift in how we fundamentally view this widespread issue. You know, you often hear people say, oh, I have a disease called sciatica. But as we're about to see, that is entirely the wrong way to look at it.
The absolutely crucial point to understand right out of the gate is that sciatica is just a symptom. It's not a disease itself. Think of it like a giant blaring alarm bell ringing in your leg, warning you that there's a fire somewhere else, specifically up in your lower back. You see, the sciatic nerve is literally the largest and longest nerve in the human body. It runs from the lower back, right through the buttocks, and all the way down the leg. So when it gets irritated, inflamed, or compressed at its root, well, that's when the alarm rings.
And to put this into perspective, adults right between the ages of 30 and 50 are the demographic most commonly affected by this. It's incredibly widespread right during these prime, active working years, which is exactly why understanding the true mechanical nature of this thing is so fundamentally important for us.
Moving on to Section 2, Anatomy and Root Causes, the mechanics of pain. Okay, so we know the alarm is ringing, right? But how exactly does the fire start? Let's zoom in on the microscopic pathophysiology here and see exactly how this massive nerve gets pinched in the first place.
Now, what's really interesting here is how this breaks down into an exact 7-step mechanical failure. It's basically a chain reaction. It usually kicks off with step 1, where an intervertebral disc starts to degenerate. Then, tiny tears develop in the outer ring, the annulus fibrosus, which allows that inner jelly-like stuff, the nucleus pulposus, to herniate outward. This directly compresses the nerve root. But it's not just physical pressure. Look at step 5. Chemical inflammation also flares up right around the nerve. This toxic combo is what gives you that radiating sciatic pain and eventually things like muscle weakness or numbness.
Now, while a lumbar disc herniation is for sure the prime suspect, and by far the most common cause, there's actually a whole lineup of mechanical issues that can pinch that exact same nerve highway. Conditions like spinal stenosis, degenerative disc disease, or even piriformis syndrome can all trigger that exact same sciatic alarm bell.
Let me act as a quick medical translator here for a second, just so we can differentiate between these main culprits. Discogenic sciatica means the nerve is being compressed at the spine level, right at the bulging disc. Lumbar spinal stenosis, on the other hand, is an age-related narrowing of the actual spinal canal, so it's physically crowding the nerves. And then you have piriformis syndrome, which is a muscle-level entrapment. That's where a really tight muscle deep in your buttock pinches the nerve as it passes underneath. So, same alarm bell, completely different triggers.
Which brings us to Section 3, Symptoms and Red Flags, the lived experience. We're going to shift our focus a little bit here to understand what standard sciatica actually feels like for a patient versus what constitutes a true immediate medical emergency.
So these typical symptoms represent the standard presentation of a compressed sciatic nerve. Patients almost always describe it as this sharp, shooting, or burning pain that radiates below the knee. And things like sitting, coughing, or even just sneezing can instantly spike the pain because those actions increase the pressure inside the spinal canal. Basically, think of it like the pinched hose effect, but happening inside your leg.
Okay, I actually need to drop the energy for just a second because this next part is incredibly serious. The symptoms you're looking at right now are emergency medical red flags. If there is loss of bowel or bladder control, numbness in the groin area, which we call saddle anesthesia, or a rapidly progressive weakness happening in both legs, that points to something called cauda equina syndrome. This is severe nerve compression, and it requires immediate emergency surgical intervention to prevent permanent damage.
And knowing all that brings up a really great question, one I actually want to pose directly to you. When is an MRI actually necessary? Because I think the common expectation is that every single person who tweaks their back needs a super expensive scan on day 1.
Well, modern clinical guidelines are brilliantly clear on this point.
We don't just scan to scan. Even though an MRI is absolutely the gold standard for visualizing nerve compression, it is only clinically indicated if you have those emergency red flags we just talked about, or if your symptoms just won't go away after an adequate trial of conservative care. Bottom line, we scan when the physical exam tells us to, not a moment before.
All right, Section 4, Evidence-Based Treatment Pathways. Movement is medicine. Let's bring that optimistic energy right back up. Because this is where the empowerment narrative really takes off. Patients have active mechanical control over their recovery here. Movement truly is medicine.
When you synthesize the dense guidelines from these massive global organizations, we're talking the APTA, WHO, NICE, a really unified consensus emerges. The overwhelming medical community favors movement over medication and definitely over immediate surgery. The old days of prescribing weeks of bed rest for back pain, they are long gone. Exercise therapy is the first-line treatment across the board, and surgery is reserved only for severe or persistent issues.
So, how do physical therapists actually treat this? Well, they use some really highly specific, evidence-based mechanical tools. Over on the left, you see the McKenzie method. This uses extension exercises to physically push the herniated disc material away from the nerve. The goal is to centralize the pain, bringing it out of the leg and back up to the spine. On the right, we have neural mobilization, or nerve flossing. This uses targeted movements to physically free up the sciatic nerve from any sticky, inflamed tissue so it can glide smoothly again. But here's the catch. Those manual therapies always have to be paired with active core stabilization and everyday ergonomic strategies. You've got to build a strong core with exercises like planks and bird dogs and combine that with correcting how you sit in your car and mastering safe lifting mechanics. This is essentially how you bulletproof your back against this ever happening again.
Section 5. Prognosis and clinical cases. Real-world recovery. Okay, let's take all of this, the medical theory, the anatomy, the guideline data, and let's ground it in some real-world patient outcomes.
Let's look at this slide and see how this all builds into real life. Notice how different root causes demand highly customized, non-surgical treatment plans. For instance, a 35-year-old office worker with a disc herniation, they're going to thrive on that extension-based McKenzie method. But an older adult with spinal stenosis, they need the exact opposite, flexion-based therapy to open up that narrowed canal. Meanwhile, an athlete with piriformis syndrome needs soft tissue work and nerve flossing. One size definitely does not fit all.
Now, I want you to focus on this number, 6 to 12 weeks. I really want to emphasize this timeline because it is incredibly encouraging. The vast majority of patients with sciatica improve within the 6 to 12-week window just by using those conservative, evidence-based physiotherapy methods, without ever needing to step foot in a surgeon's office. The source material sums this up so beautifully, and I want to read this directly to you. It says, "Sciatica can be painful and frightening, but most people recover without surgery. Early diagnosis, evidence-based physiotherapy, regular exercise can relieve pain, restore movement, and help patients return to daily life with confidence. It's just a highly optimistic prognosis when it's managed correctly."
Which leaves us with this final, provocative question to wrap up our explainer today. Knowing now that the pain in your leg is literally just an alarm bell, are you just trying to muffle the symptom, or are you ready to actually address and fix the underlying mechanics? Thank you so much for learning with me today, and keep utilizing that structured, mechanical mindset for your own health.